I'd first like to thank you very much for inviting me to speak today. It's been a really interesting afternoon, and I hope that I can contribute something to the afternoon's discussions. So my background is as a nurse and midwife originally, and then I kind of fell into genetics and became a genetic counsellor at one point because of my work in midwifery, etc. So that's kind of my professional perspective, I guess. I've worked at the university for 10 years, and I educate health professionals about genetics and genetic counselling. So I was given the remit to talk about genetic counsellors and primary care, and what I want to cover is actually what is a genetic counsellor, because I imagine that there may be some people in the room who haven't actually had personal contact with such a person. How we as genetic counsellors interact clinically with primary care, but also how we can support, especially regarding direct consumer testing, which has been some of my work, and support for education, which is another aspect of my work. So this is a quick quiz. You don't have to put your hands up, but I'd like you just to think about the thing that connects these three sets of people. And Peter referred to one of them earlier, so and if you hadn't heard about her, I'd be very surprised, but I wonder if you know about the others at the moment, and I'll come back to that in a while. So what's a genetic counsellor? So in the UK, a genetic counsellor is someone who's often educated at master's level in genetic counselling, and that goes for the whole of Europe as well. But we work very much as part of a multidisciplinary team. So in contrast to some other countries, we don't have people who set up as independent professionals working as genetic counsellors alone. We always work within the NHS usually, but with our medical and laboratory colleagues. And what's different between a genetic counsellor and a medical geneticist is that kind of extra focus, I think, on the counselling and psychosocial aspects and the educational aspects of our work with patients. Another important difference is that genetic counsellors are not trained to make a clinical diagnosis, and so that's very different from our medical colleagues. I said they're usually trained going through a master's route, but there are actually a number of genetic counsellors in the UK who also have a nursing or midwifery degree and train doing additional courses in both genetic science and counselling. So we have a kind of a route that comes through the university route and the nursing route, and we meet together and do 2 years of additional experience in a genetic centre before we can be registered. And the way that genetic counsellors are registered in the UK is that we present a portfolio, and that's used to assess our competence. I'm chair of the European Board of Medical Genetics, and we've started a process similar to this in the last 2 years in Europe, but actually the UK is further on than most other countries in Europe with regard to the use of either genetic nurses or genetic counsellors. But the European definition, and I just want to pick out a couple of points here, of what a genetic counsellor is able to do. And one is assess the chance of disease occurrence or reoccurrence, and that's using family history and often genetic test results. So we are trained to interpret genetic test results, to provide education, and that's both to patients but also other health professionals, to promote informed choice, and I'll come back to that in a while, and also to help people who have a risk of a genetic condition or are affected by it to access the appropriate health resources. And so often in the genetic service, the genetic counsellor is like the key worker who tries to bring other resources together to support families. So how does it work with primary care? Well, for many years I worked in clinical care and actually felt that the rapport between myself and primary and secondary care was really key to patient care. And I think the need in primary care, and Imran's gone through this really already, but a key point is that the primary care practitioner has to be able to recognise when there's a potential genetic condition in the individual or family for whom they're caring, and use algorithms to decide whether referral's appropriate or whether reassurance is appropriate, and to encourage those preventive strategies and surveillance that might actually reduce the risk in that family, but also to be aware of the limitations of genetic testing, and there are still a great many limitations in practical testing in the NHS. A last issue is being aware of the potential for unexpected findings. So whenever we do a genetic test, particularly using the new types of technologies where we're looking at the whole genome or whole exome, is that there is a high potential to find out something you didn't expect. Imran referred to the studies that have been done with genetic counsellors working with primary care, and there's two main studies that took place. One is Nicola Drury and her colleagues in 2007 were funded using the NHS white paper money, I think, to provide an additional support service to general practice in their area. This happened in the Nottingham area. And that was shown to be really helpful in enabling GPs to gain confidence and knowledge about genetic conditions. But of course the funding was limited and was withdrawn after a while. And Greta Westwood actually did a trial in Southampton where she went into general practice and offered genetic counselling in general practices. Again, that was really just moving the same service out of the secondary care facility into the general practice facility. It was more convenient for patients, but it wasn't shown to be any more effective for patients. So the clinical reality actually at the moment is that the specialist genetic services are located in every region in the UK, and actually how the support works is usually on an individual basis. And I know that my genetic counsellor colleagues want to be very accessible by phone or email for discussion of individual cases. And we know that in educational terms, just-in-time information works very well, and I think having access to someone that you can seek information from seems to work fairly well. Of course, that can't happen in every case because the GP would spend all day on the phone. I want to kind of bring this also into secondary care because we talk about mainstreaming of genetics, and that's been mentioned a few times already today. But genetic testing is increasingly, of course, being offered outside of specialist genetic centres. And so medical practitioners, but also specialist nurses, are heavily involved in that already. I run some courses at Plymouth mainly for specialist nurses and in genetic science counselling and clinical tools to use with genetics. And they come from a wide range of specialisms: oncology, cardiology, neurology, haematology, diabetes, etc. And what I have the impression is that they come with a really high level of expertise in their area of practice, but have lacked the genetic science underpinning their practice, and so they come to top up with that and enable themselves to be upskilled to offer genetic testing. And so within their area of expertise, cardiology, etc., they are actually doing the pre-test counselling, organising the testing and giving the results and helping the patient to adapt to and interpret the results. If you look at the literature, actually, patients seem to prefer this model because the person who they know who's giving them care in the primary care or secondary care clinic is actually the person they best relate to, who they're going to have a long-term relationship with. And so I think this is the way that we're increasingly moving, and it can only benefit patients. So, want to talk about actually dealing with results. And you'll all know the story of Angelina Jolie. She caused a worldwide upswing in referrals to the genetic services for breast cancer risk assessment. And she knew she had a family history. To her BRCA mutation results were expected. I want to just highlight the fact that I talked about incidental findings, that sometimes the results of genetic tests are very unexpected, and it's essential that we consider this and have some mechanisms in place to be able to support patients when this happens. A woman called Eunice Lee with her baby, and during her pregnancy, when she was 10 weeks pregnant, she had sort of tests that Imran was talking about just a few minutes ago, non-invasive prenatal testing. So a blood sample was sent from Mrs. Lee to Sequenom lab to see if her baby had Down syndrome. And when she went back to see her obstetrician, she was told that she required tests for cancer, because what had been analysed in the DNA within her, there's fetal DNA, but of course the majority of the DNA that they're looking at is hers, was showing some aberrations that were consistent with her having some sort of a tumour. And so a completely unexpected result for her, and she went on to have cancer investigation and cancer treatment. And apparently this is not a one-off case. Sequenom have reported that they've had 26 of these cases where they've actually identified a high risk for cancer in the mother. I think I just want to go back to Jill's talk really, when she was talking about the fact that if someone has a genetic test for one condition, in the States now it's recommended that they have another 56 tests for other conditions. And the announcement of this caused a huge furore in Europe, and to some extent in the States too, I have to say, because it's very difficult to prepare someone for that amount of potential incidental results. Well, they wouldn't be incidental because they're looking for them. And so I think, these are developments, but the technological developments are often well ahead of our ability to support patients in the clinical situation. And I think I just want to flag up that that's probably, for me, the most important area. And we should be, hesitant about introducing something before we have mechanisms in place to support patients. So, with regard to direct-to-consumer testing, and I'm sure all of you who are here will know that this became far more high profile a few months ago when 23andMe started to advertise on the television about a genetic test for £125. You could have more than 100 different genetic variants or conditions looked at using this test. So they were available in the UK before then, but they've become higher profile. And usually the direct consumer tests offer a kind of a combination of different kinds of tests, some mutations that would be involved in a monogenic disorder, such as some BRCA mutations, some carrier tests for recessive conditions, susceptibility testing for common diseases, a few pharmacogenomic tests, and some just kind of physical characteristics. And the tests are really marketed as tests that will empower people and enable them to have more control over their future. And the evidence, mainly from the States, I have to say, is that some people want to use these tests because they can maintain secrecy. They don't have to divulge the results to their general practitioner or other health professionals, and can keep it quiet from people like employers, etc. Let's So this leads me to the Thunderbirds, and I'm of an era where my children actually watched this, and I knew them very well. But the whole point about this is that some of you might have seen last week in the Telegraph that the son of Jerry Anderson, who created the Thunderbirds, had taken the 23andMe test. And he had done that because his father has Alzheimer's, and he wanted to see whether he had a high risk of developing Alzheimer. And he, fortunately for him, felt that his risk was that he got back from the 23andMe test was very reassuring to him. What I would say about that is that if his father's quite elderly, and so it's unlikely he has one of the inherited forms of dementia, but if that was the case, then this would be a fairly poor way to go about finding out about your risk, and it would be far preferable to find out what the mutation is in his father and then check for that, because we have no way of knowing whether the test that Jamie had actually did test for the same mutation that his father might have. So in general, when you're thinking about why patients might turn up at the GP surgery saying, should I have a direct-to-consumer test? We did a study, we've done a project on this and looked at why people might want to have a test, and if they have symptoms or if there is a family history of a genetic condition or other predisposition, it's preferable that they go via the health service. As part of the Urogentest project, we developed actually a tool for GPs to use that is like a decision tool. So when a patient comes and sits in the surgery, they can ask what's the motivation for having such a test and talk them through the benefits and limitations of using a direct-to-consumer test in this particular situation. And that's available online, and I'll show you the URL in a moment. But for most common diseases, actually the kind of routine lifestyle discussion that you have with patients about diet, exercise, that kind of thing, is more predictive of most of the common diseases than doing a test that shows the variants. And Peter mentioned before one of the exceptions to that, which is age-related macular degeneration. Celiac disease is another one because there are strong associations with a very few variants. So you may actually be discussing what is indicated on a genetic test, but is not indicated when you look at lifestyle factors with that particular person. And I'm always wary about when people say, you know, if we know about our genetic predisposition, it'll make us more likely to undertake preventive measures. We all know that exercise and a low-fat, low-sugar diet's good for us, but you know, how many of us actually adhere to that, knowing that it will have such an impact on our health? So this is the URL, and I'll be very happy to send that directly to anyone if they want to access that decision support tool. And finally, with regard to education, we have just been awarded an Erasmus Plus grant to look at primary care education with regard to genetics. And this is a project covering 6 European countries, including the UK. We're developing online education specifically for primary care, and going to use a kind of case-based approach. So each short module is going to be based on one clinical encounter. But evidence shows that just education isn't enough to help people utilise the information. So we've actually added in a care bundle, or we'll be adding in a care bundle, which will include things like the algorithms, the national guidelines for referral, that kind of thing, so that it's really practical and useful to primary care. And so people will be able to complete these modules in their own time, but we're also providing just-in-time information, hopefully for GP desktops, so that they can get that information when the patient's actually sitting in front of them. And this is just a list of the sort of clinical encounters. Some of them have been mentioned a few times already today, that we're going to be using to build the modules around. And we will have a website up and running, and it's primary care genetics. So hopefully some of you may wish to look at that. So finally, I'm going to go back to Osler too, quite popular today, but and I feel that he said many things that were really prescient with regard to genetics and medicine. And he, of course, said medicine's the science of uncertainty and the art of probability. And I think I just want to finish by saying that, you know, uncertainty and probability are very difficult concepts when we're working as either health professionals and working with patients. And I hope that a combination of working between the genetic specialists and primary and secondary care creates the best outcome for patients. Thank you.